Good morning, everyone. I think we can start in the interest of time because there will be another session at 11:35 onwards. So, good morning and welcome to our session on the impact of family planning on women's health and socio-economic status. My name is Moazzam Ali. I work in the Department of Sexual and Reproductive Health at WHO based in Geneva. And with my team sitting here also, I'm going to introduce them later on. We are going to present a series of presentations on looking at various aspects on how family planning impacts women health, adolescent health, empowerment, agency, and as you'll see later on in very in-depth detail. Just as a background, investing in family planning is often positioned as a cost-effective intervention for enhancing maternal child health. It also has an impact on improving socioeconomic status, contributing to a sustainable development globally. Now, the available evidence, as we are all familiar, suggests that the family planning definitely contributes to improve women's health by reducing unintended and high-risk pregnancy primarily. And ultimately, it leads to a decrease in maternal deaths and morbidity. There is also some evidence that it reduces the risk of some gynecological cancers. It also has impact in reducing severity of menstrual conditions. It also decreases, like I mentioned, many non-reproductive health and reproductive health issues like osteoporosis and some mental health aspects as well that we are going to highlight during the presentation. At the same time, there has been some challenges, some skepticism, I would say, that people still in the public health community consider that some of the evidence is not as strong as it should be. So, keeping these aspects in mind, and we are all familiar with this estimates of the Guttmacher Institute that what is the impact if we are able to meet the unmet need of family planning, especially among the developing regions. I don't have to go through the different percentages. And also, back in 2012, a very dear friend, Dr. Saifuddin Ahmed from Johns Hopkins, he also modeled that using the 2008 data, that family planning has averted 44% of maternal deaths. And he estimated that 340,000 deaths should have been reported, but due to the use of family planning, it was reduced to 272 or 240,000 deaths. And it was also estimated that if unmet need for family planning is met in the developing regions, further 29% can be prevented, and maternal deaths can be prevented. So keeping all these aspects in mind, we had certain questions that we thought it is better to revisit, to try to answer. So we looked at 4 research questions. Does contraceptive use improve women reproductive health outcomes? That is the first review that we are going to present. Does the use of contraceptive family planning affect non-reproductive health outcomes for women? Does family planning use empowerment and strengthen the agency of women? That is another interesting aspect we thought we should look into. And last but not least, looking at these aspects from adolescents' point of view. So these were the 4 questions as a team, along with our partners, we looked into, and we agreed that these should be further explored or revisited. So when we were thinking of revisiting these, we also thought instead of going alone and doing the systematic review, why not engage some of the key lead researchers or the key persons who have been working in this area for a long time, who have a better understanding of all these issues from all various different aspects. So I reached out to the colleagues written here, and we formed a technical advisory group, including Professor John Cleland, Professor Herbert Peterson, Harriet Birunji, John Townsend, Iqbal Shah, Anne Biddlecombe, Professor Sonali Desai, and Manala Makua. So these people cover a range of areas from data, from policy perspective, programmatic perspective, looking at the whole aspect from country perspective, and also from global perspective. So what we did was we had a number of meetings with our technical advisory group when we were designing, when we were moving ahead in doing the research of the articles, and now at this stage, now as we are coming to the end of the systematic reviews. I must mention that this is the slide that you're going to see. These are not 100% final, but we are sort of coming towards that. So you'll see the direction. Some of the interpretation, some of the finalized things will be done in the coming couple of months in consultation with the technical advisory group. And I think some of the questions that will come from the audience will also help us to refine and look at various aspects from different angles. So that will be very, very much appreciated. We also had to select colleagues who would do the systematic review. So we had the call for research proposal, RFP, and we widely distributed, and we selected 3 teams who are with us today and who are going to present. These are the different research questions that each of the team is presenting. Sorry, I took the pictures from your website, so they may not be very latest, but bear with me. So you will see them in person. So Nadia Diamond Smith from University of California, Dr. Zora Lassi from presentation. We are going into the details of the methodology, and then whenever there is a little bit of difference or contextuality regarding different things, we are going to stop at that particular slide for maybe adolescent is a little bit different compared to women, or maybe some other things in empowerment. So they are going to highlight those areas which have not been covered. So in the first presentation, we will have all the details. So, and we are going to have all the 4 presentations back to back. And at the end, we will have, I'm sure, sufficient time for Q&A and for your feedback. So first of all, I'm going to request Nadia Diamond Smith to come and make presentation to look at, does family planning use empowerment and strengthen the agency of women? Dr. Nadia Diamond Smith is an associate professor in the Department of Epidemiology and Biostatistics, Institute of Global Health Sciences at the University of California, San Francisco. She has a PhD from Johns Hopkins and MSc from London School of Hygiene and Tropical Medicine. She studies the intersection between women empowerment, reproductive, and maternal health, mostly in South Asia. Over to you, Nadia, please.
Great. Thank you for that wonderful introduction, and it's great to be here today. Planning use or studies that measured either family planning current use or ever use, those were our the main predictors. And then the outcomes were outcomes related to empowerment and agency, and I'll talk a little bit more about some of the details of trying to measure those things. We know that empowerment is a complicated measure. We had a whole session on it yesterday. I think I see a couple of familiar faces, but we included a broad range of measures that have been conceptualized as empowerment, and I'll talk about that in a minute. And the part of our inclusion criteria was that the studies had to report on a quantitative measure on the effect of family planning on empowerment or agency. We looked in peer-reviewed articles that used the following study designs: RCTs, controlled clinical trials. We also included quasi-experimental studies in our approach. That might have some differences across the studies that used different regression discontinuity designs, difference in differences, et cetera. And we also looked for longitudinal or panel studies, cohort studies, and interrupted time series. Exclusion criteria were mixed method studies that didn't include one of those above quantitative measures, qualitative, or cross-sectional studies, and I'll talk about that a little bit more in a minute for this paper specifically. We did keep qualitative studies that were relevant to look at later on after we did our review to sort of help us understand the pathways and the findings that we were finding. So our focus was papers published between January 2000 and 2022. These are the databases that we searched. I think that there is general commonality between our approaches in terms of ours. We were interested in how family planning impacts women's empowerment or agency, not the other way around. And so we were really narrow, really focused on only including studies where we knew that the family planning, either exposure or use, came before the measure of empowerment. And this, I think, really sets it apart from previous work that's, broadly looked at the association between family planning and empowerment, which is, I think, and I think even within that body of work, most of the papers have been framing how does empowerment impact family planning use? Do more educated women, are they more likely to use family planning, things like that. But we were really, really narrowly focused on what about the reverse? We situated our thinking about empowerment and how we chose to, which papers we chose to include based on Kabir's framework, theoretical framework for understanding empowerment. This is actually a model by Yant et al., which kind of expands Kabir's framework, but empowerment is conceptualized as having a domain related to resources, agency, and achievements. And what's important to highlight here is that empowerment is conceptualized as a process. And that's something that we talked a little bit more about in the session yesterday, but is something that we really found to be missing in how the papers that we included were measuring empowerment and our understanding of what family planning does for empowerment. So just the conceptual model that we as a team came up with to really think about why we think contraceptive use might impact these different domains related to fertility. And that's something we thought a little bit about. We didn't come up with a good way that could happen, but we wanted to, we thought perhaps through knowledge of contraceptive access or use, allowing women to delay marriage it might not directly impact fertility and could potentially feed into this pathway, but I think it's something that I would love to hear any thoughts from the audience on as we come to our discussion section. We also noted that there are bidirectional pathways here where we thought there could be some feedback loops, where certain domains of empowerment might feed back to help women, be able to delay or space their births more or limit fertility, and then feed back into each other. This is really busy. These were our search terms. The main thing I want to note here is that we made a decision that all the papers that we were including had to be saying that they were trying to measure empowerment. So if they were just looking at an outcome like schooling, but they didn't frame it as women's empowerment, we did not include it in our analysis. So therefore, all of our search terms related to empowerment had to include something that was like very close to empowerment in it. So we didn't include just like labor force participation or something like that. We conducted our search in March and April of this year of those 20 databases I mentioned earlier, got over 11,000 papers. There was a lot of duplicates. After extraction, we came up with a total of 21 papers, 18 from the quantitative literature and 3 qualitative. I'm going to quickly go through, we did assess the quality of the studies. In all, 3 studies were categorized as fair and 15 as good. And then we did a grade assessment to look at bias and from a few other countries. So what were the interventions that we found? So 16 reported on actual interventions or some type of natural experiment, and 4 reported on non-intervention exposures. Many of the papers evaluated systems-level interventions. I mentioned those ones from Bangladesh were all about the Matlab study, which is, was like a long-standing maternal child health intervention in Bangladesh, which I'm sure all of us are very familiar with. 5 of them were natural experiments. There were fewer studies that evaluated actual interventions that targeted the facility or individual level, so there was only 3 RCTs in our review. And this just kind of was a way of thinking about sort of like the different types and levels of interventions that we found. So some of them were just looking at exposure being the provision of family planning. Others had the provision of family planning, but it also included some kind of counseling or behavior change intervention, messaging. Some of them included those 2, but then had an added layer of something related to either like life skills, relationship skills, or engagement of the community. And we struggled a little bit with this here because we were like, oh no, does this actually include the empowerment with the family planning? So should we exclude these studies? But we decided to include them because we still felt like the thrust of the focus was on the provision of family planning. And then there was a few sort of ones that focused on like policy changes, like access to the pill in the US. Those US ones were mostly sort of these studies like that looked at changes in laws related to access to the pill and things like that. So in terms of moving on to the outcomes that were in those papers, so resources were included in the other review. So we could have, if one wanted to include things like birth outcomes, as an achievement, which I think there would be a strong argument for doing something like that, then we might have picked up on more achievements-related outcomes in this review. But we'll get to hear about those findings in a few minutes. And interestingly, most of the papers only measured across one domain. And I think this is something that, as someone who measures empowerment, is interested in empowerment, was really striking. If we want to think about empowerment as a process, which I think we should, we would hope that we would be measuring empowerment as a process. But that's not something that we found was done very commonly in the papers. So to the impact. More papers found positive impacts on empowerment outcomes compared to null or negative impacts, although there was a number of null reports and a few negative findings. Looking by those domain of empowerment, that's how we chose to sort of understand the impact of these. So for the resource, 50% of those that measured a resource-related outcome found positive impacts. This was similar across. So, across those different types of outcomes that were measured, most of the resource-related ones found positive impacts. For those that found negative impacts, it was 13% of those in the resources, 15% for agency, 0 for achievements. Again, remember there was only 3 papers that measured an achievement-related outcome, so this is really slicing things pretty finely. And then again, null results were about or similar across the 3. So I think this is very interesting that, even when we look at the bucket of what type of empowerment was, we found pretty similar distributions of how many were finding positive impacts on that outcome, how many null, and how many negative. We higher income countries and low and middle income countries, and there were no null or negative results in the studies in high income countries. However, again, many fewer papers. So just to sum up, so our finding is that overall, most of the papers did find a positive impact on the empowerment outcomes measured. Some null, fewer negative outcomes. So I think that this is an exciting finding, and for those of us interested in how family planning impacts women's status more broadly across their lives, should lead us to be hopeful. Of course, as I mentioned, we should think about publication biases always with null results, especially, even negative ones. The biggest proportion of null results were in resources and economic related outcomes. This might just be because it was the biggest sample. Most of the papers measure these type of outcomes. And, I talked about this a little bit in the presentation yesterday, but, we really thought a lot about why so many of these papers are measuring these sort of economic, resource-related outcomes instead of thinking about empowerment more broadly. And we wondered, why we have this over-reliance, and is it because that's just an easier thing to measure? Is it because we've sort of been stuck in this framing of empowerment as like an economic thing and not thinking about all the other important aspects of empowerment? And I think it's something for those of us working in this field to really consider as we're trying to conceptualize and measure empowerment. One thing also was, we were sort of surprised at how hard it was to find interventions that were really in some of these things into our studies. And as we know, empowerment is very complex, and it was very hard to compare across these studies that were measuring things like wages compared to things like, women's decision-making power, or even like achievements, their feelings of self-worth and aspirations. All right, I'm going to stop there, and thank you all so much for your time.
Thank you very much, Nadia. Excellent overview of how family planning impacts the empowerment and agency of women. Now from women, we move to adolescents. And I'm going to invite Dr. Zohra Lassi. She's a trained epidemiologist and recognized internationally for her work in identifying intervention for improving reproductive, maternal, newborn, and child health, and of course, adolescent health in disadvantaged settings. She has published over 150 peer-reviewed papers and is author of 11 book chapters and several technical reports. She is a PhD and is currently affiliated with Robinson Research Institute and School of Public Health of the University of Adelaide in Australia. So over to you, Zohra. Thank you.
Thank you, Dr. Mozum, for this introduction. As Dr. Mozum and Nadia has already discussed, the topic is exactly similar, only the population is different. So instead of women, we have family planning for empowering and strengthening the agency of adolescent and young women. All right, so conceptually, we do recognize that the relationship between modern contraceptive use and empowerment among adolescents is complex. And we propose that in order to assess the impact of family planning on adolescent empowerment through various outcomes, including resource domains like education and employment, and agency domain like decision-making and freedom of movement, do we need to start from the use of family planning and look at the outcome related to empowerment and strengthening? Or should we also start with the interventions that starts from empowerment and agency and look through the outcome on the use of family planning? And therefore, we decided to go both directions. So this is different from what the first review has done. So this is just a conceptual framework displaying that we started in both directions. We looked at studies that started with empowerment and agency and reported on the use of family planning outcome. And we also looked at study that started with the use of family planning and reported on the empowerment and agency outcomes. Quickly go through the methods, which are a little bit similar, but there are some differences that I would be highlighting during the presentation. This was registered. We followed 2020 PRISMA guidelines. The PICO is we define family planning and how we define empowerment, which was covered in the earlier presentation. Just want to highlight that empowerment is multidimensional and can be social, political, economic, educational, psychological. So we kind of covered all these things, and we included all those interventions that talk about any of these dimensions as part of empowerment. Outcomes, since we were going both ways, so the studies that started with the use of family planning, we looked at the empowerment and agency outcome, mainly given in this figure below. But the studies that started with empowerment agency, we looked at the use of family planning outcomes from those studies specifically. This is just a logic grid showing all the different terms that we have included, and Nadia has already covered that in detail because there were similarities across the reviews. This is just the different databases that we have looked through and searched for these studies. So from almost 8,000 records that we identified, we ended up including 39 studies. We also identified 5 ongoing studies, and of course the results from those studies are not published, so we did not include those. So basically, if we look at the divisions of those studies across different study design, there were 27 randomized and cluster randomized trial, and 12 are the non-randomized control trial. If we look through the different regions, most of the studies were published and coming from Africa and American regions. Gender specific, 7 of the studies were specific delivery platform. There were some studies on school-based delivery platform, digital platform, and use the health clinics as well. This is how we tried and classified the empowerment. This is still under discussion, and we might be modifying this, but this is how we have classified how the empowerment interventions that we ended up including in the studies. So most of those studies were on sexual and reproductive health empowerment. There was only one that talked about, that included other societal agents for the empowerment interventions. So we classified them separately. 2 of the studies had sexual and reproductive health empowerment with capacity building of the adolescent and young women. Socioeconomic and health empowerment we identified, and there was one study on health empowerment with capacity building and vocational training that was provided to adolescent and young women. The plan of synthesis and analysis, we decided that we would be analyzing the outcome based on the different classification of empowerment that we have devised. And within that, we will look through the outcome based on what study designs they have, what gender they have targeted, the age of the population, the delivery platform, the region the studies was coming from, and based on other factors, that is their educational status, marital status, employment status, sexual activity. However, we could not perform any analysis because it was not uniformly reported in those studies. Majority of the outcomes, since majority of the studies that we identified risk as well. So talking about the RCTs, only handful of the RCTs were high quality, which are marked in green. Otherwise, majority of the studies had some concerns and high risk of biases involved as well. All right, talking about the ASRH empowerment and how family planning was reported in those studies, we found that the sexual and reproductive health empowerment led to increase in the use of any contraception use, but we did identify that it was reported as any modern contraceptive use, regular contraceptive use, ever use of contraception, and the initiation of contraception. And we graded all these outcomes based on the quality, and these are the grade analysis with that. When we looked at the unprotected sex as an outcome from the studies that had ASRH empowerment, we found that it reduced unprotected sex significantly. And again, it was reported sex without any contraception or sex without condom. I mean, we divided those into these 2 categories, and we can see that the grade quality was very low for this outcome. As we decided that we would be doing some subgroup analysis because there was a lot of different heterogeneity that was involved in the included studies, we also performed some subgroup analysis based on the study design. So you can see that these are the results from the RCTs. Some of the results are coming from non-RCTs. Although these are significant, but we can see the heterogeneity is very high in India and based on region as well. Again, we saw that the heterogeneity is very high, and on grade it is low to very low. Again, the other empowerment studies that we identified, one was ASRH, which targeted to improve or change the societal norm. These are some of the outcome. Again, this is only coming from single study, and we have mentioned where exactly it is coming from. And these are just these are some of the outcomes that we could analyze from this study. ASRH empowerment with capacity building. There were only 2 studies included in this particular pooling of the results, and these are some of the outcomes that have been reported. Financial and health empowerment. There was only 1 study that talked about this kind of empowerment, and these are the results from that study. And health empowerment with capacity building and vocational training. Again, there was only 1 single study, and these are some of the outcomes that were reported in that study. Just to conclude, all the studies that we identify, mainly majority of the studies started from and talked about empowerment and agency development that led to the use of family planning. Empowerment was assessed very differently as we have categorized them, sometimes with capacity building, sometimes with vocational training, sometimes the dimension of empowerment was different and it was financial empowerment. Most of the studies that assess the impact of SRH empowerment reported on any use or ever use of contraception or regular use of contraception. Some of the outcomes were rated as moderate. So we need some longer follow-up studies that assess the longer-term outcomes of family planning use on all domains of empowerment outcomes. Of course, this has been highlighted in the earlier review as well, that we need some validated measures on empowerment, which is a process. That can be, used for different populations, different geographies. Of course, empowerment is very different for different geographies and for different age groups as well. And we need some robust quality and robust studies on methodological grounds so that the heterogeneity can be minimized and the results can be used efficiently. At the end, I would end my presentation here. I would like to acknowledge all the co-PIs, one of the co-PIs sitting in the audience here, and the research team, and of course WHO for the funding and the TAG group. Thank you.
Thank you, Zora, for a wonderful presentation. Now for the next one, in fact, it will be two back-to-back presentations by Dr. Jahanfar. And Dr. Jahanfar is a reproductive epidemiologist with a grounding in public health and biostatistics. She has 2 PhDs in Obs and Gynae and also in healthcare and epidemiology. She has worked in academia for 25 years. She is currently associate professor at Tufts School of Medicine.
Maternal mortality and morbidity, and the second will focus on non-reproductive health outcomes. So a bit of background, we all know that high maternal mortality and morbidity rates are a concerning global issue. We know that family planning contributes to reducing maternal mortality and morbidity, and we know this through the literature, through different methodologies that have been utilized. For example, the MATLAB series of studies that have been done a while ago, or through the comparison of estimates of surveys by Dr. Saifuddin Ahmad, as my colleague mentioned, or through model-based reviews, such as the one that John Cleland have published. So we basically know that, but the reason we really want to go back to this question is to come up with those interventions and exposures that solely focuses on the use of family planning and how they interfere with the maternal health and maternal mortality and morbidity outcomes. And so we basically went through the project by focusing on mortality and morbidity, and then looking into the conceptual framework of, okay, if you have a history of use of contraception, whether it's an emergency contraception or whether the contraception has failed and as a result we got pregnancy, and basically how that plays out in terms of maternal mortality and morbidity. And then if we have contraceptions used in the screening, for the RCTs, we meant to use Cochrane methodology, but obviously you know that Cochrane frowns upon observational studies, so they're not supporting that kind of methodology, so we had to come up with our own kind of reviews that have been proved scientifically that are valid to work with observational studies. But we also, as we were looking at these different studies, we came across many studies that we were not able to pull together, because as you know, when you're pulling the data together, those data should talk about the same comparison, the same outcome, the same study design, and they should have the same even outcome measured. So you can't pull dichotomous and continuous together, obviously. And even, if you have outcomes such as time-bound outcomes, they have to be pulled separately. So we ended up actually doing some forest plot, but we did a lot of narrative reviews as well, because we felt like there are studies that do not fit in any of these characteristics. So we have to avoid pulling them together and basically just come up with a narrative review. So the flowchart updated here because I use the word updated because we actually run two different search. And the first search that I have not highlighted here were about 13,000 paper, and this is the second one that will focus on observational studies. And you can see the different types of countries that we had. I think we had a good mix of studies, and we finally found 17 observational studies looking into this. Screenshot of the characteristics of papers that we provided, but obviously I'm not going to go through. Now, the narrative reviews on maternal mortality are plenty, and I'm just using a few items here, and I'm not even going through the numbers because I'm sure you're exhausted at this point, but some of these studies looking into averted disability adjusted life year, and you see the numbers here. This study looked into maternal mortality decline after use of contraceptions, and Gupta also only focused on implants, looking into reduction in crude live birth, maternal neonatal mortality, and also the number of women who has been suffering from high-risk pregnancies. As for maternal morbidity, as I said, it's really hard to pull these studies that are not talking about the same thing. So as often I explain this to my students this way, that if you have a basket of fruits full of bananas, then it just has one fruit, but that's exactly what you want to have, so you can have less heterogeneity. But if you have a basket of fruits full of different fruits, then you will have so many different types of populations and different types of interventions and all that. And so that's basically lead to a high heterogeneity. So we have to be really, really careful what type of studies we pull together. Just had a narrative review, but then focusing on a few concepts. So contraceptions, we found that not in use, that it's a preventive measure against preeclampsia. There is a high risk among users on both venous thromboembolism and ectopic pregnancy. And as for implication for practice, we think that attention to factors contributed to contraceptive use and unmet needs is necessary. We know that the primary cited causes of unintended pregnancies include lack of contraceptive use, use of ineffective contraception methods and contraceptive failures, and the incorrect or inconsistent use of effective contraceptive methods, that all of these should be taken in consideration for future reviews. The screening of pregnancies resulted from failed contraceptives and during postpartum period is also necessary. So basically, if you want to give a message to a clinician, you have to say, contraception is necessary and positive, but be careful. You have to screen these women, especially those who got pregnant immediately after failure of contraception, just to make sure they do not suffer from the side effects. As for implication for research, we feel that we should think about prioritizing exploration of the effect of both hormonal and non-hormonal modern methods, focusing on one method and non-hormonal modern methods, focusing on one method at a time, because what we came across is that we found some studies that are combining different things and trying to find here. I think the final message at the conference, and I heard it over here in so many sessions as well, that we should really think about analyzing these data by viewing it with diversity glasses as well. How does contraception actually impacts different races and different ethnicities? And I think perhaps we have been doing some of that through subgroup analysis, but we haven't really started the study by that. We usually tend to look at it at the very end stage when we are analyzing the data, but don't design the studies looking into this issue. So that's my final message for this. And I have a long list of people to thank for. The advisory group and also my MPH students who have been tirelessly working on this project, and obviously Dr. Muazzam Ali, and the Cochrane and Fertility Group. Can I have the second presentation? Are you tired, exhausted? You want to stretch out a little bit? Okay, I promise it's going to be painless and quick. So this one is going to focus on non-reproductive health part, and we aim at identifying and evaluating evidence that focuses on the use of contraception and their impact on evaluating evidence that focuses on the use of contraception and their impact on non-reproductive health outcomes among women of reproductive age. So the outcome allocation, concealment, etc. And so what you see here is a risk of bias assessment overall for the RCT piece. And so we had 74 studies that were only observational, and we used the black and down weight, and you can see that the average of quality was 13 out of 28. And so overall, 41 study provided evidence of high quality according to our criteria. 26 had moderate and 7 had low quality. So I tried to use the great pro approach to summarize the information, because that usually works better with the policymakers in the room rather than taking you through the numbers, which could be painful. But you can see some numbers. So when you see a standardized mean difference, this is what we use for continuous variables that have different tools utilized. So for example, endometriosis-associated pain is presented as continuous variables, and you can see that those who have been on contraceptive, according to 5 RCTs, which included 672 people, with high quality of evidence, have lower SMD compared to the non-users. So it seems to be like it has a positive effect. So if you use contraceptive for endometriosis-associated pain, you get relief, and that's a positive effect. Again, you see this for endometriosis-associated dysmenorrhea, and this was also continuous variation, has been discussed in the papers. And you can see recovery of baseline menstrual pattern, amenorrhea by 12 weeks, menstrual blood loss, hemoglobin by gram per deciliter, menstrual irregularities, and the list is long. And you can see across that, except this one, that we didn't really have that much of an event, that much of an effect. And literally, it's a very low effect as well, because you need to think about significance in terms of statistical significance versus clinical significance at the same time. So you basically see that you have good effect from contraception all over. Here's the impact of contraception use on leiomyoma and endometrioma. And as for depression, we had conflicting results. When we looked at depression, just as reported by the patient or clinician, this is the result we found. Low quality paper, about 10 RCTs, but it shows a positive effect of a contraception lowering depression. But then some papers meticulously use a specific tool, and we were lucky to find 6 RCTs that just measured depression using this scale. And this is approved by psychology department, by the way, everywhere. And then the quality was low, but it shows a lower effect as well. So that basically shows that we have cancer going up. So that's basically, given the heterogeneity is quite high, we wanted to do subgroup analysis and sensitivity analysis, which I have not presented here. This paper actually is 70 pages long, so we're thinking about dividing it, and so it would be very, very boring for you to listen to all those. But generally, we are also thinking about meta-regression analysis for the next stage. So as for the rest of the 67 cohort studies here, you see the mental health outcomes. Some are showing just the reverse of what we found in the RCTs. And then we'll see anxiety going down and the suicide going up. Now, I wouldn't take this seriously because you have high heterogeneity, and really the quality of studies for these particular studies were low. Now, what happened with the case control studies are just the numbers were just very small and heterogeneity very high. But basically, we have lower ovarian cancer and lowering breast cancer here, but increasing cervical cancer. This is consistent with what we found with the cohort designs. So as for discussion, to summarize, we measured potential relationship between contraceptive use and reproductive and non-reproductive health outcomes. For the non-reproductive health outcomes, we found 100 studies, 16 of which were RCTs, and 74 of them were observationals, and we focused on cancer, mental health, irregular menstruation, that we should pay attention to. But when it comes to cervical cancer, we have to have the provision of screening women, and we are doing it through the screening process, doing pap smear for every woman who comes for OCP, obviously, and so that is great to pay attention to, but also the providers should select contraceptive methods according to the clinical standing of women, considering the age, physical status, and mental health status and family history when they're prescribing them, these contraceptions. As for implications for research, we know that non-reproductive health benefits of different duration of contraceptions has been touched on few papers, but this is an important question, and we were not able to pull the data together to find the answer to this very important question. So we feel that this is something that studies, new researchers should consider. As more new contraceptive methods become available, research on the benefit of different types and doses of contraceptions and their impact on non-reproductive health should be looked into, given the guidance of the clinical use. And also studies that studies of the effect of contraception on women in disease or conditions that we didn't look into should be further explored. With that, I'd like to...
Before we go into that, may I ask my colleagues to please come on the stage so that we can take the questions. And so please feel free to raise your hand and ask the question, introducing yourself. And perhaps if it is directed to any specific colleague for that particular question. We have one at the back. Can we give the mic? Okay, please.
Hello, everybody. This is Soumya Ramarao. Thank you so much for the presentations today. This was excellent. I had a comment, rather, and to think about what we might do with this information going forward, and especially around the outcomes that were presented in the first two, around empowerment and so forth. I worry that if we don't find any effect or limited effect, and the data quality is poor, about the association of family planning to these wider socio-economic reasons, then what does that mean? We don't want investments in family planning to drop, right? So we do have to be...
From that, I was looking at, we work in a program where there is women's empowerment, livelihood, and family planning. But what we see is women's empowerment, livelihood should help older women, and family planning needs up to younger women. Thank you that you participated with adolescents, and the programming in adolescents, family planning is less. So how do we put the things together, looking at different age groups, looking at empowerment, and how do we match that and look at program opportunities to see whether research can
Okay, thank you. So Nadia, shall we start with you and then Zora?
Sure. Thank you for these great questions. I mean, so the takeaway that I have from that first presentation is actually very positive, right? I mean, I think that more than half of the paper showed a positive impact on women's empowerment outcomes. You know, and we tried to conceptualize empowerment very broadly, so not to be, you know, just focused on, you know, economic empowerment, but really thinking of the value to women across, from multiple domains of her life, right? Not just restricted to, and that's kind of why we did that, to your point about, like, we don't want to just invest in family planning because we know it does this, you know, small thing for women. We want to think about, like, does it improve the overall quality of her life, her hopes? We want to think about, like, does it improve the overall quality of her life, her hopes, her feeling about herself, her aspirations, those type of things. But, you know, I think that do they get a job afterwards, but can we measure this in a more holistic way that gets at the broader impacts on women's lives, you know, more consistently, or, you know, more precisely, or in a, I don't know, as a community? I mean, I think that that's the main takeaway to me. I'm not worried that our findings suggest that we should stop investing in family planning for women's longer term empowerment. I'll let Zora answer the other one maybe.
Thank you for the questions. I agree the worries are valid, but, and yes, although the studies were very heterogeneous and the quality was low, but again, it was giving some promising results, and I haven't shared all the results because some of the outcomes were coming from single study or two studies where they did report that they started discussing the use of family planning with their spouse or partners. So those results are promising. They are going somewhere. I mean, these interventions are leading to that path. And of course, as we were discussing yesterday, this adolescent and young, this adolescent period is actually so short that maybe when you start delivering intervention at this stage, you might not see the outcomes in the same life stage. I mean, you can see the results even afterwards. So yeah, I mean, even the results are not how we wanted to appear, but these are promising as well.
Okay.
Can I just say one more thing to the second question in terms of, you know, what we should do as people working on programs? And, you know, I think that, I mean, I think the answer is, you know, where this review we were trying to look at, as to sort of related to that other point I had, like, this, I think the field has already moved on to realizing these things, so it's harder to find studies that, like, just look at these, like, one single factor type of interventions.
Thank you very much. I would
can I
say
just
one
make a
last,
point?
oh, sorry, you want to say something? Apologies.
As for what you mentioned about how do we mix this adolescent studies and the women on the reproductive age group, you know what my dream study looks like as an epidemiologist? A retrospective cohort or prospective cohort looking at the same individuals from early adolescence to womanhood and then forward. And this is what's missing really, and for obvious reasons, because it will be extremely expensive to do this type of thing. But what we mostly have at international level or country level data, we do have a lot of cross-sectional studies, and we know that the cross-sectional designs and surveys are flouted because of the temporality issues and directional issues. So those are not going to be, you know, our real answers. But the true answer comes from following people through time and basically monitoring them. So one of the famous studies as epidemiologists we talk about is Framingham study, which was a heart study, or nurses studies, and or physician studies. That this has been done in other fields. Why not?
So there were a couple papers that looked at the impacts on the children of the women who were exposed to family planning in our review. I don't know about the other ones. One of them was in the U.S., a paper by Bailey that, like, looked at sort of like that next generation of women who were exposed to the pill. So, and that was what we included those in the like achievements category, because we kind of thought that as like the women being able to achieve something. Because in the qualitative work, which I didn't get a chance to talk about, that was one of the things women talked about a lot, is like, if I have fewer kids, then, you know, I can invest more in them. And so we wanted to see, like, does that play out. We conceptualize that as being a marker of her achievement. So, so that is something that we found at least one paper that looked at. But again, I think this gets to this point that we don't often have longitudinal data that follows women long enough to see, like, what happens to the kids that were born at a time that they were wanted, like, what happens to the women who are able to plan their pregnancies. I can say we are doing a study in Nepal. I don't know if you guys are familiar with the Turnaway study that happened in the US that looked at women who were denied abortion and got their abortion. And we're doing that in Nepal now and comparing these very things, like what are the outcomes of the women? It's like a slightly different question, but who were able to have a pregnancy at the time they wanted versus those that had, were denied access to abortion. So, but it's a really great question. I don't know if others have.
So I think we are coming to the end of the session. We must appreciate it's a complex area of work, empowerment, mortality, morbidity for women, and looking at from the lens of family planning.